Good morning, good afternoon, good evening to all the participants from different parts of the world. I am Dr. Shivakumar, the lead consultant of Pediatric Cardiology and Adult Structural Interventions at the Madras Medical Mission, Chennai, India. Happy to join you all. We are going to show an intervention in a 35-year-old lady who had a cryptogenic stroke with no previous comorbidities. I have Dr. Pramod Sagar, who is the imaging consultant, who will be performing the transesophageal echocardiogram. Dr. Anand Kumar, who is one of my fellow and who will be assisting me. And Dr. Tejasvi, who is one of the postdoctoral fellows, who will be presenting the details of this patient. Over to you, Tejasvi.
Yes, thank you, sir. Today, our patient is a 35-year-old lady who is an engineer by profession who has had no comorbidities except intermittent migraine episodes for which she was on SOS analgesics. She was apparently well till 1 month ago when she developed history of sudden onset weakness involving left upper and lower limbs with no associated headache, blurring of vision, slurring of speech or seizures. She was managed with dual antiplatelets with complete recovery within 2 days with no residual neurological deficits. Her vitals were stable, her saturation was normal. No, she had a normal CVS examination, and on CNS examination, she didn't have any residual neurological deficits. This is her chest X-ray and ECG. The X-ray shows a normal heart shadow with no abnormalities. The ECG shows sinus rhythm with normal QRS axis and normal LV forces. We evaluated in detail. Her baseline investigations were all normal. Her thrombophilia workup, including protein C, protein S, antithrombin 3, lupus anticoagulant, ANA, and homocysteine, were all negative. She had a normal CT carotid and cerebral angiogram, and transthoracic echo showed no structural heart disease with normal chamber dimensions and good ventricular contractility. Her MRI brain showed an acute infarct in the right capsuloganglionic and corona radiator regions with normal cerebral angiogram. The ROPE score, which is the risk of paradoxical embolism score, her score was 8, which showed an 84% probability that the cause of her stroke was probably can be a PFO. We'll go on to the transesophageal echocardiography. Here you can see that there is a small PFO which is shunting left to right in the first image. There is a still image which shows the shunt across the PFO. We then did a bubble contrast echocardiography to her, where on Valsalva maneuver you can see that there a few bubbles escape into the left atrium. Over to you, sir, for the live case.
Oh, thank you, Dr. Tejasvi. Thanks for the presentation. Now, I would like to just clarify on 2 points that you presented to me. Number one was you told that there was all the thrombophilia screen were negative. That means you probably screened for antithrombin 3 deficiency, factor 5 laden mutation, protein C, protein S, antiphospholipid antibodies. So that was a reasonably good thrombophilia workup. That probably tells us that she is not a candidate for very recurrent venous thromboembolism. And the second thing that you mentioned, Dr. Tejasvi, about the ROPE score, the risk of paradoxical embolism. Can you just clarify on it? What is ROPE score and what is relevance?
Yes, sir. So ROPE score is a score which is helpful in predicting which of the patients with a cryptogenic stroke that is attributable to a PFO. It basically gives us an objective evidence of the causality of a PFO to a cryptogenic stroke. The total score is 10, which comprises of 5 individual points, 1 point each given for no history of hypertension, no history of diabetes, no history of prior stroke or TIA, for being a non-smoker, and for having a cortical infarct on imaging. All these points get 1 score each. The remaining 5 points are given based on the age, with patients less than 30 years having a score of 5, and progressively up to 70 years, more than 70 years is a score of 0. So a maximum score of 10 means that is a patient less than 30 years of age who has no vascular risk factors, who has no history of stroke or TIA, and who has a cortical infarct. And these patients have the highest risk, that is 88% probability of having the PFO as a causal relationship to the cryptogenic stroke.
So that's excellent. So in other words, you are telling that in a young patient who is around 35 years, who is non-smoker, not a diabetic, not a hypertensive, I mean, no atherothrombotic atherosclerotic risk factors, and the patient is young, and you would probably give a lot of weightage for a PFO with the right to left shunt if you are getting it, if this patient gets a cryptogenic stroke.
Yes.
And in this particular patient, probably it may be worthwhile considering a PFO device closure. Okay, now Dr. Pramod, you acquired some images of transesophageal echocardiography at the beginning. Can you just go through and try to find out whether there were any cardiac reason that could have resulted in a cardioembolic a stroke?
Good morning, everyone. You have already witnessed the transesophageal echo that was shown earlier in the PowerPoint. We are doing now a transesophageal echocardiogram under IV sedation using dexmedetomidine. This is initially we screened to look for any evidence of other causes. This is the aortic valve. We can see that the aortic valve is trileaflet with without any thickening or any abnormality. If you see it in a explain, this is the long axis of the aortic valve, which shows the cusps are normal with normal mobility without any thickening, and this is the mitral valve, where we can see that in a 0 degree the mitral valve leaflets appear normal, and this is the color which shows there is no significant mitral regurgitation. This is in the long axis view, where we can see that the mitral valve is normal with very trickle of regurgitation which is not significant. This is the left atrial appendage. You can see here, this is the mouth of the left atrial appendage, and in this we can see that there is no thrombosis, and on pulse wave Doppler we can see that there is there is clear the contraction of the left atrial appendage that is documented. So then coming back to the septum, this is the septum in the 0 degree view. This is the atrial septum, this is the aorta, and this is the left atrium, and this is the right atrium. Here actually we can see a small flap of tissue. On color, currently we are not seeing very good color flows in this. I'll just try to show it live.
Okay, Pramod, yeah, that's good. So basically, you have excluded mitral valve abnormalities such as, say, a thickened mitral, fleshy mitral valve prolapse, an aortic valve abnormality such as calcification or a vegetation or something on the mitral valve that could be aortic valve that could be responsible. You also demonstrated that there is a normal atrial contractile velocity that says that the left atrial appendage is normally contractile. There was no historic evidence of any atrial arrhythmia. There is no thrombus in the left atrial appendage primarily. So we are now showing that there are no features of cardioembolic stroke apart from the PFO that you are currently demonstrating. You are able to see the septum secundum and the septum primum, and between the two there is a minuscule flow. Primarily now it is from the left atrium into the right atrium. So since we have demonstrated right to left shunt of the agitated saline contrast in the outpatient clinic a few days ago, so let us go towards the vascular access. Primarily in these patients we take only a vascular access with venous route alone, and that is largely guided by ultrasound. So what we'll do now is an ultrasound guided right femoral venous puncture. The patient is currently on dexmedetomidine sedation being managed by the intensivist Dr. Uday, and one of the reasons why we don't try to intubate a patient who is having a patent foramen ovale with a possible cause of paradoxical embolism. You know that the right left shunt is seen when there is a negative intrathoracic pressure. It's during the release phase of Valsalva. So if the negative phase of Valsalva means it is a negative intrathoracic pressure, and when you are positive pressure ventilation on full general anesthesia, you obviously will not be able to get it. So actually the patient is kept very comfortable with dexmedetomidine infusion that is running, and I mean she seems to be tolerating our transesophageal echocardiogram rather very well. So now we are demonstrating the femoral vein here, and now I'm going for the femoral venous access and the ultrasound guidance. So we are now, that is the vein. So we are entering into the vein. So we have entered into the vein under the ultrasound access with an 18 gauge needle. So now we are introducing a standard 038 J-tipped guide wire, and that is followed by a 6 French normal valved introducer sheath. At this point, we'll give the full dose of heparin. What is the weight of this patient? Normally we give 100 units per kilogram. So she's 71 kilograms, so we are giving around 7,000 units of unfractionated heparin. Can I have a little bit more saline flush? Fine. I need a multi-purpose catheter. I need a multi-purpose catheter. So while we are waiting for the multipurpose catheter, can I do some agitated saline injection? So what I do for an agitated Pramod, I'm going live. Okay, what I do for a yeah. So this is the agitated saline that is being injected. You can appreciate clearly that there is a. Can you increase the proximal gains?
Maximum gain.
Yeah. So during each inspiration, you see that there is a shower of contrast. Pramod, like it's quite spectacular, Pramod. You are showing beautiful images. And I am finding that with each of her inspiration, there is so much of shower. You see that? See the amount of contrast that is entering the left atrium. Normally they say you have to calculate the number of bubbles, and here there are hundreds. See that? See the amount that is crossing over from the. So I think it is quite convincing that we are dealing with a situation which needs a closure. So can you get me the wire inside at present? Yeah, thank you. So we are having a 6 French multipurpose catheter that enters the heart. So as a routine, we would like to get some hemodynamics just to ensure that there is no pulmonary hypertension, ensure that there is a normal pulmonary artery pressure. So currently we are entering into the pulmonary artery and we are going to be documenting the pulmonary artery pressure. Pramod, what will be your protocol for checking the activated clotting time? What I follow in my unit is if after giving the unfractionated heparin, I wait for about 30 minutes and find out whether within the 30 minutes I complete the procedure. And if I complete the procedure, then I don't go for a routine monitoring of the activated clotting time. However, if the procedure exceeds 30 minutes, then at that point I will start doing the ACT assessment. We are now having pulmonary artery pressure. There is a lot of respiratory fluctuations that are seen because of the patient being on a conscious sedation. However, we are finding that the pulmonary artery mean pressure is around 20 millimeters of mercury, which is normal. So now we are coming into the right ventricle. The right ventricle pressure too is normal. Now coming to the right atrium. Again, it's showing a lot of respiratory variation due to the deeper levels of sedation. And so now I have crossed through the patent foramen ovale. Now put a 3D there and show me. It just walks through the foramen ovale. So this is left upper pulmonary vein. I'd like to get a stiff wire, an Amplatz super stiff guide wire. Followed by that, I would like to get the Amplatz PFO delivery system. So currently we are getting in with an this is a super stiff guide wire. Pramod, is the clearly it is through the patent foramen ovale?
Yes, it is clear.
You can give your comments on the imaging that you are watching now.
No, I will show it in 2D first. We can see here, this is in the 90-degree bicable view. Now we can see that, you can see the
holding.
this is the patent. This is the patent for foramen ovale, and we can see that this is the bright structure, that is the wire that has passed through this patent foramen ovale into the left atrium. I'll put a explain that would make it more clear.
Now you have actually lifted the septum primum and the septum secundum by the wire. Can you measure the distance between the two septum? It seems to be just about 3 to 4 millimeters, right?
Yes, I can measure once. It's like 3 millimeter.
3 millimeters. Okay.
3.5
Okay. Now,
millimeter.
also, can you find out what is the distance from the aortic root, and you can also explain how do you choose the device based on the distance from the aortic root.
This right on the right side of the screen, whatever we are seeing is the short axis image, where this is the point of crossing and this is the aortic valve. This is almost 180 degree because this is a 90 degree and this is a X-plane of it, which is 180. So this is the aortic valve and this is the region of the like retroaortic. This is the retroaortic region. From here to here, if I measure now, it comes to
Fluorostor.
quite lot of, like it comes to almost 15 millimeter here, but I'll recheck again.
Can you show that on a 0-degree plane itself so that our measurements are even more clearer? Yeah. Now that's a good view. Can you put a color on this area? Okay. And once you are seeing the color, can you find out what is the, I want an underwater, 1 second. Can you get more saline?
Sir, a question.
Yes,
now
please.
we crossed the PFO quite easily. If it was, if you were finding it difficult to cross the PFO, were there any additional steps that can you please explain?
Yeah, in some of the patients who have an extremely long tunnel, sometimes it becomes very challenging to cross. These are the situations where the left atrial entry of the foramen ovale will be at a very superior level, whereas the right atrial exit will be at a very inferior level. And this is a long tunnel-like foramen ovale. That is one area that will give rise to a lot of difficulty. Here, in fact, there is not too much of separation at all. The separation was very negligible, and hence probably it was quite easy to cross. Your question was quite valid. Sometimes what will happen is, if there is an extremely long tunnel, and if we are going through a long tunnel like foramen ovale, sometimes we will use balloon sizing. In that balloon, we will see what is the length of the tunnel, and if the length of the tunnel is too long, sometimes it may be a good idea to puncture the atrial septum just close to the right atrial exit of that atrial septum, and then get the sheath across, so that the non-self-centering PFO devices will be able to approximate the tunnel far better, rather than putting the device across the entire length of the tunnel. Here in this patient, there is no tunnel at all. Do you agree, Dr. Pramod?
Yes, sir. We don't see any tunnel here.
Yeah.
I measured that time, it was just 3 millimeter here.
Yeah.
And this is just
Wire tip,
this is
yeah.
the wire tip, and there is no, and this is the septum, this is the tip of septum secundum, and this is the tip of septum primum. So we don't find any difference, any large.
What is the length between the aortic root and the?
Now I have measured the length from this PFO to the aortic root.
It's around 10?
Around 10 millimeters.
Okay. So we will keep that in mind. Now let us concentrate on the way in which we are de-airing. So currently what we have is the Amplatz torque view delivery system. The long delivery system is kept here, and we are holding it with underwater, and because the patient is on spontaneous like respirations, there is going to be a lot of negative intrathoracic pressure, and so there may be a possibility of an air embolism. So currently what we are doing is slowly removing it and allowing, in fact I'm keeping the guide wire also inside. The reason is to prevent the guide wire, prevent the sheath from getting wedged within the pulmonary veins. And so there should be a free backflow of the blood. Now you are seeing the blood gushing through. It's a good gush through of the blood. So now, having satisfied with the amount of blood flow, now I am withdrawing the guide wire. Sister, coil the wire, please. I am keeping the I'm keeping the sheath. Now I'm putting my thumb and I'm controlling it. So at this point, I'm aspirating. I want a 20 ml syringe with a lot of saline. Okay, that's good. So now we have got the sheath across. So this is a 10 French sheath across. And you were mentioning that the distance between the foramen ovale and the aortic root is about 10 millimeter. So if let's assume I am choosing the smallest PFO device, which has got 18 millimeter on the left atrial side and 25 millimeter on the right atrial side, I probably should not be encroaching onto the aortic valve. Don't you think, Pramod?
Yes, sir.
Okay, so let us open an 18 by 25 PFO device. 18 by 25 PFO device. It's by the Abbott Medical. So once we open, we will show the device. We're getting a beautiful view of the sheath going from the inferior vena cava, going all the way into the all the way into the patent foramen ovale. So let me connect it to the three-way. So this is the three-way system. I will DR the three-way system. You can put in the light here. So we are DRing the So this is the Amplat's torque view delivery system, and this has got an 18 millimeter disc on the left atrial side and a 25 millimeter disc on the right atrial side. The right atrial side is intentionally kept larger because our primary intention is to prevent a right left embolism. So at this point, we are going to load the device.
Brightness.
The light is interfering. Okay, cut off the light. So this is the PFO device. I'll just show. I'm recapturing the right atrial disc. You can appreciate clearly that it is a non-self-centering device, which means the waist is very small, and the entire right atrial disc has been now captured. Now what we have is only the left atrial disc, and the left atrial disc is also captured now. So I will open it again. So at this point, what we'll request is, sister, can you flush out? Keep on flushing. Keep on flushing. That's wonderful. Thank you. Close it. Can you flush once again another 10 ml of saline? Close it. Perfect. So now what we are going to do will be, so we have locked the Amplatzer delivery system, and show me live TE. So right now we are advancing the 1825 PFO device through the 10 French. Yeah, it has reached the left atrium. I'm able to see that the device is actually past the sheath. You can see that the sheath lumen has become opaque now. I'm going to open the left atrial disc in the left atrium and going to draw it back.
Yes.
So it's nicely getting approximated against the atrial septum. So this is the right atrial disc. Can you capture the fluoro and then show us? Show the image. So this is the left atrial disc that has been deployed. We bring it close to the atrial septum. And the right atrial disc is getting deployed. Okay, so that looks fine. So can we
Yes.
check it on a 90-degree view? Yeah, that's fine.
And now we can see that this is the 90-degree view. This is the superior vena cava, and this is the inferior vena cava, and this is the device. The LA disc is clearly seen, that is smaller disc which is seen on the left atrial side, and this is the RA disc which is seen clearly within the RA. Because of some tension on the cable, it looks angulated, but once we release, it should be becoming flatter.
Okay. So the position you are satisfied,
The
Pramod?
position
Okay.
is good.
Let me just
There is no color.
before release, let me do an agitated saline injection. Yeah. So right now I am injecting uh, agitated saline with blood into the right atrium. So I'm having a good filling of the right atrium. Can you capture it when the right atrium is getting filled, Pramod, so that you can
Yes.
have a replay of it?
Sure.
So that's a good filling. Can you show me a replay of
I'll just
that?
play it again.
Yeah.
This is the recording that we have done.
Yeah,
We can see
sure.
that the right atrium is completely filled with the bubble contrast, but we can see that there is not even one bubble of contrast that is crossing into the left atrium. So it is
Fine.
good. There is no there is no flow of contrast. There is no right to left shunt as of now.
Yeah, that's excellent. Pramod, that's very reassuring. So right now, I will do one thing. I will release the device so that, we should be able to check it. We can see that the screw is getting slowly unscrewed.
Yeah, now it is.
So there is a complete release now.
Now in the
The,
TE, we can see that the discs are both the LA and the RA discs are well aligned, and we can see that there is no this is the left atrial disc which is smaller, and the right atrial disc which is larger, and both are well aligned with the atrial septum. Good that this patient didn't had a very large aneurysmal floppy septum that could be there in some patients, but this was a good case where we can see that there's a well alignment of both the disc, and color also shows there is no flow of any there's no shunt across any there's no residual shunt anywhere.
Pramod, now that I have completely released the device, can I do once again another agitated saline injection?
So ready
I
for
am now giving.
firing.
So there is a reasonably good swelling, a good contrast opacification on the right atrium. Can you take one image on a 0-degree plane so that we see in the other axis? Yeah, that's good. That's good. So
Are you still doing contrast, sir?
I'm actually filling the right atrium completely, but we are not able to see anything going across into the left atrium. Now I'm giving a good injection. You are not able to see the contrast in the right atrium because of the shadowing created by the large device. But one thing is clear that there is no bubble that is entering into the left atrium. We want to show some three-dimensional view of the left atrial surface of this device.
Sure, sir.
Uh, yeah, figure of 8. Just a second. On this side.
So do you routinely use figure of 8 sutures to secure the site for large sheets?
Well, we can give a manual compression also. We can, it's just a 10 French sheath. We can give a manual compression. We can put a figure of 8 stitch, and about maybe 3 to 4 hours later we can remove it. Tejasvi, what will be your antiplatelet strategy or an anticoagulation strategy in this patient? What was the medication that this patient was on following that previous episode of stroke?
She was on aspirin, sir. She was started on aspirin and atorvastatin also.
And was she on Plavix also? Was she on clopidogrel as well?
Right now, when she came to us, she was only on aspirin. But
Only aspirin. That will be primarily if suppose there was a documented paradoxical embolism with an MRI showing a clear-cut stroke. There are various schools. Some people will give aspirin plus coumadin. Some would give aspirin plus Plavix. Some people will give aspirin plus DOAC, either rivaroxaban or dabigatran or apixaban. Only aspirin maybe like in I mean it'll be inadequate. Anyhow, having put in a device, my protocol will be I'll probably give her aspirin and Plavix for 3 months. At the end of 3 months, repeat another agitated saline contrast and demonstrate that there is no right-left shunt, and downgrade the antiplatelets to a single antiplatelet, only aspirin. Probably continue that till 1 year after the intervention. Repeat a bubble contrast study at the end of 1 year again to ensure that there is no right-left shunt. And once I am happy, then probably at the end of 1 year we will withdraw.
yes.
About atorvastatin, if her lipid levels are normal in a menstruating 35-year-old lady, and if these lipid levels are not warranting a hyperlipidemia treatment with the statin, I probably will withdraw statin. I may not be very much inclined to continue statin for a longer period of time. You are showing good images. This is it the left atrial view, Pramod?
It is from the left atrial. This is a 3D acquisition from the left atrial side. We can see this is actually from the left atrium. This is the septum, and this is the uh, left atrial disc. We can see here, and if I turn it to the right atrial view, here we can see that this upper one is the superior vena cava, and this is the larger right atrial side of the disc.
Thank you very much. So that was Pramod, you have actually demonstrated that there is no right-left shunt in the across the foramen ovale, and the device is in a stable position. Now we have to take out this 10 French sheath, and as Tejasvi was pointing out, one of the option will be to give just a normal manual compression. Another option will be to take a figure of 8, so that we are currently taking a brief figure of 8, which will keep for about 3 to 4 hours, and at the end of 3 to 4 hours withdraw it. But once her effect of dexmedetomidine goes off, we will probably take it out. So the figure of 8 is taken with one bite just above the sheath and one bite just below the sheath, and we'll tighten it out. Is there any questions from the participants of the meeting in the...
No, right now we do not have any questions.
it probably is a very simple intervention, Tejasvi. However, it has, you have demonstrated very nicely an agitated saline injection, how it caused a significant amount of right left shunt, especially during inspirations. Pramod, you want to show one image in case if you have acquired the right left shunt.
Yeah, sure, sir, sure.
So
Okay.
regarding the role of transcranial Doppler in these patients with cryptogenic stroke.
Yeah, transcranial Doppler is another extremely useful technique wherein basically we can avoid a transesophageal echocardiography to document, but it needs the high intensity signals, the hits that you are going to get on the transcranial Doppler should be quite nicely validated by a good radiologist and this picture that you are showing, Pramod, currently with each inspiration a bubble of I mean this is what is primarily the reason why we may think about doing a PFO closure. In fact, I was mentioning to you at the beginning that we try to avoid a positive pressure ventilation for the patient, like putting on full general anesthesia, because sometimes what happens is in full general anesthesia with a positive pressure ventilation, the intrathoracic pressure is so high that you will not be able to demonstrate a clear right left shunt. Whereas in a spontaneously breathing patient, during each inspiration, there is a negative intrathoracic pressure, and that sucks in the blood from the superior and inferior vena cava, which results in torrential contrast spill. See, can you freeze and just show us the number of bubbles? There are some people who do a bubble count on the number of bubbles that enter the left atrium. Here, probably there may be 100. It's quite a lot. So. Now we will look at the groin. The groin is clean. There is no bleeding at present. So we will put in a small primopore plaster here and shift her into the recovery room till the effect of dexmedetomidine weans off, and then she probably will be discharged from the hospital in another 24 hours by tomorrow on aspirin plus Plavix, and with a plan to see her at the end of 3 months for a repeat bubble study. Thank you very much, Pramod, for an excellent imaging, and thank you, Tejasvi, for moderating the session, and thanks, Dr. Anand, for assisting me. Thanks, Dr. Uday, for keeping the patient comfortable on dexmedetomidine. Prabhu and Ravi, the cath lab managers, for giving us all the support with all the gadgets. The Abbott Medical, which provided the PFO device. It's an excellent device, and we will probably meet on another day with another interesting intervention on the same session. Thank you very much. Goodbye to all of you.